Thank you all for joining the virtual ACC Kentucky chapter meeting. And I would like to thank the ACC Kentucky chapter for giving me the opportunity to present today. My presentation would be on ischemia trial, invasive versus medical treatment in stable ischemic heart disease patients. This presentation was originally intended for live audience, but due to the ongoing pandemic, we have changed this to virtual presentation. I wanted to be more interactive and I had more live cases to discuss, but since this is going to be an on-demand program, I'm just going to try to be as comprehensive as possible and try to keep this brief. I'm not sure who the target audience are going to be, but the original presentation was intended for all medical students, residents, nurse practitioners, physician assistants, and all the primary care providers, and also, of course, the cardiologist and interventionalist. So I'm just going to be as brief as possible and also try to touch the basic highlights of what the study was meant for and what the outcomes are and how this is going to change the clinical practice. So even when the trial was started, there was a lot of talk as to how the study was designed, how this is going to be carried, and what are going to be the outcomes. And there's been a lot of controversies and a lot of debates and a lot of news about this trial, and especially when the trial came out in 2019, it was in news extensively. The headlines went anywhere from not every patient with a blocked artery needs surgery, finds new cardiac study from stents and bypass surgery are no more effective than drugs for stable heart disease. Highly anticipated trial result shows, as you can see in major news journals. Of course, like news journals are just going to highlight what the results were rather than focusing on what the real study showed. So there was a lot of debate among patients. I personally had so many of my patients ask about this because I'm a practicing interventional cardiologist, and I mainly see patients who are referred to me like for having either a coronary angiogram or even an intervention done. So there was a lot of controversies and a lot of questions in people's mind after hearing the news. So I'll just try to give a brief outlook of the whole study, and we'll have some conclusions and take-home points at the end of the presentation. So we all know from before that chronic lesions are not like the reason people have heart attack. This has been well proved, well validated. Multiple studies from basic labs to clinical outcome studies have shown that it's not like the chronic blockages that people have make them have an acute heart attack. And why is that? Because chronic lesions are more fibrotic, they are more calcified, and they are less prone for rupture. When people have a heart attack, either it's like a non-STEMI or a STEMI, it's due to an acute plaque rupture exposing the thrombotic milieu in the endothelium that causes rapid accretion of thrombus, clot, and blocked arteries. And this doesn't happen in patients who have chronic stable blockages. But these patients might have chest pain, and these patients will have non-invasive studies done for chest pain, which will be positive. Could be either a treadmill stress test or a perfusion imaging study. So the ischemia trial mainly focused on those subgroup of patients who have chronic angina and who had a non-invasive evaluation performed for evaluation of the angina, and which was positive. And what do we do with those patients? Whether medical management is sufficient, or do these patients need more invasive evaluation in terms of coronary angiogram, stenting, or open heart surgery? So that was the main research question that was intended to answer in this largest ever randomized trial. So in stable patients with at least moderate ischemia on a stress test, is there a benefit to adding invasive management if feasible? to optimal medical therapy. And this is how the study design is. So patients who had angina had non-invasive imaging. Then it could be either a stress echocardiogram or a stress myocardial perfusion imaging study. Could be a stress MRI or a regular standard Bruce treadmill stress test with no imaging. I will go through each one of those inclusion criteria in the stress modality. But if the patient meet any of those inclusion criteria, if they had a positive study in any one of these non-invasive evaluation, the next step they had was a coronary CT angiogram, which is really interesting how they did in the trial. And this is probably one of like my favorite things about the whole trial is to like adopt like coronary CT angiogram for a more anatomical definition of coronary arteries. So patient then had coronary CT angiogram, and again I'll go through what the inclusion exclusion criteria are based on CT angiogram. So the CT angiogram did demonstrate they had coronary artery disease or blockages. Then they were randomized into two arms. The first one was the conservative arm, where people were managed with guideline-directed medical management, which mainly included aspirin, statin medication, and also risk factor control with aggressive control of diabetes and blood pressure management, and also diet and exercise. And of course, smoking cessation, which includes the risk factor control. And if they were successful, and if their angina was controlled with antianginals, then they didn't have any further invasive evaluation. So if they had persistent angina, then they were crossover of those people because of the failure of conservative therapy. And then the second arm was patients who had positive non-invasive evaluation were randomized to invasive evaluation in addition to the conservative management. So a total of about 8,500 patients were enrolled. There were about like 3,400 patients who were not enrolled because of exclusion criteria. And among those 8,500 patients, of about 5,100 patients were randomized equally to the invasive arm and the conservative arm, and they were followed up for 3.3 years. And there was pretty good follow-up in those patients, and almost up to like more than 90%. So in terms of the inclusion criteria, like the age has to be more than 21. The moderate or severe ischemia based on a perfusion imaging was quantified as more than 10% of LV ischemia, which usually is like some stress score of greater than or equal to 7. If it's a stress perfusion imaging study. If it's a stress echo, then more than 3 segments of stress-induced moderate or severe hypokinesis or akinesis. If it's a cardiac MR, there has to be greater than 12% of ischemic myocardium. Or if it's a stress MR, there has to be more than 3 segments of stress-induced severe hypokinesis or akinesis. If it's a regular treadmill standard Bruce protocol stress test with no imaging, then there has to be greater than or equal to 1.5 millimeter ST depression and greater than or 2 leads, or more than 2 millimeter ST depression in single lead at less than 7 minutes with angina. So the major exclusion criteria in the trial, which is very important to know because these subsets of patients won't apply to regular clinical practice. So anybody who has heart failure with class 3 to 4 NYHA, functional class classification, patients who have unacceptable angina despite maximally tolerated medical therapy, patients who have cardiomyopathy with EF of less than 35%, patients who had ACS within prior 12 months of randomization, patients who had a PCA or CABG within a year prior to randomization, and patients who are on dialysis or who had end-stage renal disease with the GFR less than 30 were not included in the main trial, but they did have a subset of ischemia CKD trial, but they were not a part of the main ischemia trial. Now, coming on to the coronary CT angiogram, it's very interesting, and more and more centers in the United States are adopting coronary CT angiogram and even CT-FFR with both combination of anatomical and functional assessment. So it's probably like the largest randomized trial, like for adopting coronary CT angiogram in terms of ischemia evaluation. So the inclusion criteria, when the patients had a positive stress test and then had a coronary CT angiogram, and if they had more than or equal to 50% stenosis in a major epicardial vessel, or greater than or equal to 70% stenosis in a proximal or a mid vessel, if they just had a regular treadmill stress test, both were included. And the important thing to know was patients who had greater than or 50% unprotected left main stenosis, they were excluded from the trial for obvious reason. So again, like patients who had a stress test, either could be like a regular treadmill stress test or myocardial perfusion imaging study, or it could be a stress echocardiogram or a cardiac MR. They subsequently had coronary CT angiogram. And if they did have a documented greater than 50% stenosis in one of the major epicardial arteries, then they were randomized to invasive versus conservative management. And then if they had greater than or equal to 50% left main stenosis, they were excluded from the trial. So the most common modality of the stress test that was used in the trial, though, was a myocardial perfusion imaging study, which is probably the most common non-invasive modality used in regular clinical practice, at least here in the United States. So looking at the endpoints, there's been a lot of debates when there were some changes that were made to the primary endpoints, but since I'm not going to get more in detail to it, I'm just going to go over what were the primary endpoints were. So the time to cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest, they were the primary endpoints. So it's essentially cardiovascular death, MI, or hospitalization for unstable angina. So the major secondary endpoints were time to cardiovascular death or MI and quality of life. And that was assessed based on the Seattle Angina Questionnaire. And other endpoints include all-cause death, clinical benefits, stroke was added later on, and components of the primary endpoint. So ischemia trial is the largest randomized trial looking at this particular question we had in mind, and the trial was, of course, well carried on. And if you go to the baseline characteristics, they were equally matched, starting from age, hypertension, diabetes, and other risk factors, blood pressure. And even if you look at the stress test modality, both the invasive and the conservative arm were equally matched in terms of what imaging modality they had. And even based on the results of the stress test, both the arms were equally matched in terms of whether they had only mild ischemia or moderate ischemia or severe ischemia. As you can see, like there was about 55% of patients in the conservative arm who had severe ischemia, and same goes to the invasive arm. And again, like the important thing about the ischemia trial, for me at least, is there's like 54% of the patients who had stress perfusion imaging study or stress nuclear study, and they have more than 50% of them had severe ischemia, and they were randomized to the conservative arm, which is not, like, I would say, the routine clinical practice, at least here in the United States, especially if they're having angina on top of that. So that was really interesting for me to know how those patients ended up on conservative arm. So based on coronary artery anatomy by coronary CT angiogram was pretty well matched between the two arms. As you can see, patients who had a number of single vessel disease or even two vessel or greater than three vessel disease was equally matched. And almost like 87 patients had like left anterior descending artery blockage, and they both were equally matched compared to like proximal circumflex or right coronary artery. Now jumping on to the results here. So as you can see, the curves initially were favoring the conservative arm. About like 6 months, you start to see a separation, and actually there was a crossover just before 2 years. And then there appeared to be like some signal for less endpoints occurring in the invasive arm. But of course, the difference at the end of 3 years were not statistically significant. And same goes with the major secondary endpoints. the difference, even though there was a slight benefit in the invasive arm, was not statistically significant. So this was a major debate as to if there is a more longer follow up, will there be a statistically significant benefit in terms of primary endpoints in patients with invasive management compared to conservative management? But I'm not going to talk too much about it because it was a well carried out study, and at the end of 3 years, there was no statistically significant difference between the two groups. So conclusions here are ischemia is the largest trial of invasive versus conservative strategy of patients with stable ischemic heart disease. Overall, an initial invasive strategy as compared with the initial conservative strategy did not demonstrate a reduced risk over a median 3.3 years follow-up for primary endpoint, which includes cardiovascular death, MI, hospitalization for unstable angina, heart failure, or cardiac arrest. Same goes to the secondary endpoint of cardiovascular death or MI. So the important result, other than the primary endpoint, was the quality of life, and it did show that patient had a significant improvement in their baseline angina when they had an invasive strategy approach compared to the conservative strategy approach. And this was observed in patients mainly who had angina daily, weekly, or monthly. And also there was a couple of secondary endpoints that I want to talk. There was a signal of slightly increased rate of periprocedural MI in the first 6 months when patients had initial invasive approach chosen, but there's been extensive debate as to what defines periprocedural MI. This is not the first study that periprocedural MI definition has been in controversy. On the same note, there was also a greater incidence of spontaneous MI in patients in conservative arm compared with invasive arm that was seen after 3 years. So we don't know if we will have more long-term follow-up data on these patients, and those questions might be answered if we have long-term follow-up data. So in patients without angina, an invasive strategy led to minimal symptom or quality of life benefits as compared with conservative strategy. In patients with angina, shared decision-making should occur in line treatment with patient goals and preferences. So the take-home points, the main reason for the presentation is to make sure that everybody understands that the ischemia trial population does not apply to patients with ACS. So patients who comes in with unstable angina or had a non-STEMI or a STEMI invasive management with coronary angiogram and percutaneous coronary intervention or CABG still remains first line of treatment in those patient population. So in terms of patients who have stable ischemic heart disease, we have had multiple trials in the past, including the COURAGE trial, but there's been extensive debates as to who really is a COURAGE patient and who's not. But in my opinion, I think the ischemia trial answers, or at least puts a nail in the coffin that guideline-rated medical management clearly places an enormous role in patients with significant stable ischemic heart disease. And the new thing in the ischemia trial is even if patients who have severe ischemia on a stress imaging modality, they still did okay when they were started on guideline-directed medical management, and if their angina is controlled, of course. So in my opinion, in clinical practice, we do have few patients who have angina and they are probably in the hospital for some other reason. Then they get a stress test and we see they have moderate or even severe ischemia, but they do have significant high risk for invasive evaluation in terms of having old age GI bleed issues or old age dementia. They're not good patients in terms of taking their medications if they need stents, and we see those patients quite often, and we always scratch our head as to what is the ideal treatment for those patients. At least the ischemia trial answers that question, that even if you have someone who has moderate severe ischemia on a stress test, you can clearly choose to have them managed conservatively with good medical management and follow them up more closely and see how they do. I think that's going to be an important take-home point for me. Again, like for general audience, I think we should all try to like get our patients on maximally tolerated medical management in terms of high intensity statins. We have had exciting new avenues of treatment for cholesterol, and I'm a very aggressive risk factor control management person. We have pretty good program with our ancillary colleagues, and we have like PCSK9 inhibitors, and we have like more and more new gene therapies coming in terms of patients who are not able to tolerate statins. So I think clinicians should be like more aware of all these treatment modalities available for patient. Of course, like aggressive secondary risk factor control, exercise, and lifestyle modification plays a significant role, even if you choose an invasive strategy. The bottom line would be out of all things is to make sure your patients are on maximally tolerated guideline-directed medical management for CAD. Thank you. Again, like this presentation was intended for more live audience and wanted to be like more interactive. But if you have any questions, please feel free to reach me. That's my email address, and that's my Twitter. Thank you.